Hi everybody, this is Dr. Chitra, your mentor for the week, and today we will be seeing about thyroid and parathyroid gland and the hormones. So, in the thyroid gland, we know we have two types of cells: follicular cells, which secrete T3 and T4, and parafollicular cells, which secrete calcitonin. Now, for production of thyroid hormone, iodine is essential. In the follicular lumen, you have presence of thyroglobulin. When this is stimulated by TSH, they absorb iodine, and this iodine binds to the tyrosine and it forms monoiodotyrosine and diiodotyrosine. Now, this is stored in the colloid of the follicular cells. T3, that is diiodotyrosine, is the active component. It has a half life of 1 day, and T4, or thyroxine as we call it, it is about 20 times of T3 in the circulation, and the half life is about 7 days. Thyroid is a hormone that is essential for life. Without the thyroid hormone, life is not possible. Now, let us see what happens when we have too much of thyroid or too less of thyroid. So, whenever we have too less of hypothyroidism, this is the typical clinical picture that is seen. There is edema, sluggishness, there is weight gain because of the decreased BMR, there is anemia because no production of erythropoietin, then there is cold intolerance, and you get skin and hair changes. So you can see the typical pores, dry hair, and the eyebrows also, the lateral third of the eyebrows are lost. Now, whenever there is too less of thyroid hormone at birth or in the fetus, there is presence of a condition that is called as cretinism. Because there is deficiency of the hormone, the treatment obviously is supplement the hormone. What happens when you have too much of the hormone? This is what happens. You get something called as hyperthyroidism. It is exactly the opposite of hypothyroidism. So there is weight loss, irritability, high blood pressure, sweating, tremors, and you get the typical eye sign that is called as exophthalmos or bulging of the eyeballs. Now, because there is too much of the thyroid hormone, the treatment obviously is you give some drugs that will block these hormones. They are called as antithyroid drugs. Then you can give radioactive iodine, or you can do surgery on the thyroid gland. Very important from exam point of view, thyroid changes in pregnancy. Because of the increased vascularity, there is moderate enlargement of the gland. And we know that HCG and TSH are similar. So what happens initially in the first trimester, there is an increase in TSH, and then it falls in the second and third trimester as compared to the first trimester. But however, it is still increased as compared to the non-pregnant state, but it is not above the normal levels. Okay, so this is what happens in a normal pregnancy. In a pregnancy in which there is too much of HCG, like in a twin pregnancy or when someone has hyperemesis gravidarum, in those patients, initially TSH falls in the first trimester. In the second and third trimester, there is a rise as compared to the first trimester. And this rise, it is more as compared to the non-pregnant status, but still it is not above the normal levels of TSH. Then you have increased levels of circulating thyroid bound globulin. Because TBG is increased, then there is the total T3 and T4 increases, but free T3 and T4 do not change. There is a relative decrease of iodine because of increased renal clearance, and also iodine is actively transported to the fetus because the fetus has its own thyroid gland. It starts concentrating iodine, and it has been seen that the fetus synthesizes the gland at about 12 weeks of gestation. Now, coming to calcitonin. So, this is secreted by the C cells. Remember, calcitonin. So, it tones down the level of calcium in the blood. Whenever there is excess of calcium in the blood, thyroid gland will secrete calcitonin, and this decreases the level of calcium in the blood. So, how does it do that? It inhibits absorption from the intestines. Then, in the bone, it stimulates the osteoblasts and inhibits osteoclast. So more of calcium is deposited into the bone, and in the kidney, it will inhibit reabsorption of calcium in the kidney. So more of calcium is excreted in the urine. In this way, calcium decreases the level of uh, calcitonin decreases the level of calcium in the blood. Now coming to the parathyroid gland. So there are two cells, oxyphil cells, function is not known. Chief cells or C cells, they secrete parathyroid. The function of parathormone, remember, is exactly opposite to that of calcitonin. So if calcitonin decreases the level of calcium, parathormone increases the level of calcium in the blood. So how does it do that? It will take up more calcium from the GIT. In the bone, it will stimulate the osteoclasts. So this causes increase of the bone breakdown is increased, and that releases calcium and phosphate into the bloodstream. And uh, in the renal system, it decreases the urinary secretion of calcium. So the level of calcium in the blood increases due to the action of parathyroid. Now, what about phosphate metabolism? So, calcitonin moves phosphate into bone cells and bone fluid. That means it decreases the level of phosphate in the blood. Okay. And what does PTH do, or parathormone? It reduces the reabsorption of phosphate from proximal tubule of the kidney. That means more of phosphate is excreted in the urine, and vitamin D, that also increases phosphate reabsorption in the kidney, leading to increase in phosphate level. So basically, calcitonin and PTH, they decrease the level of phosphate in the blood, whereas vitamin D, it increases the level of phosphate in the blood. So this was in short about thyroid and parathyroid hormones. I hope you found the video helpful. Thank you.